Yes, it has been 24 hours since the last video. No, I haven't gotten any better. So, yes, welcome to another lecture on diabetes for people who know nothing by a person who knows even less. Half of this material is going to continue to be flagrantly stolen from Amboss, and the rest is either me cursing or saying, don't worry about it. So, enjoy, I guess. Amboss says, diabetes mellitus should be suspected in patients with recurrent cellulitis, candidiasis, dermatophyte infections, gangrene, pneumonia, particularly if it's a TB reactivation, influenza, genitourinary infections like UTIs, osteomyelitis, and or vascular dementia. Which, fair, I guess. That is definitely a sentence. And you know what? It's definitely a fair point that you should probably start to get suspicious of diabetes in these cases. But you know what's a better fucking reason to suspect diabetes? Yeah, high fucking blood sugar. So, yeah, when your patient has a high goddamn blood sugar, you should consider that they might have diabetes. But Yara, when will we test for high blood sugar? First of all, fuck you. It's such an easy test. Do it on everyone. Second of all, fine, I'll tell you what the actual indications are. It's in symptomatic patients, so any patient that has any sign of diabetes. And if you will call back to when I talked about the classical signs of diabetes, that's pretty much any time a patient comes to the doctor and says something is wrong with me. And then asymptomatic patients who are either less than 45 years of age, who are obese and have one or more risk factor for diabetes, which, remember, we don't need to make the American joke again. Or two, any patient at all who's greater than 45 years old. So, yeah, if you look at that, it's, oh, look at that. It's fucking everyone. Literally any person coming to the doctors for anything other than a well person check, assuming they're under 45, just get a blood sugar. Just get a blood sugar. Also, fuck it. That person who came in for the well person check, get a blood sugar. It's not going to hurt them. It's like one drop of blood. Okay, dope. So now I have a blood sugar level. What am I going to do with it? Which is, we're going to try and diagnose them with we're not going to try and diagnose them with diabetes. Ideally, we won't you know what? Let's just restart that, shall we? So now you have a blood sugar level. Now we're going to look at it in terms of its diagnostic criteria. So the diagnostic criteria for when you can say that someone, based on their blood sugar level, has diabetes mellitus is a couple of things. So it's any single random blood sugar level that is greater than equal to 200 milligrams per deciliter. That might not be right. No, that was actually correct. I can do numbers. I'm a genius now. Anyways, so any single random blood glucose level of greater than or equal to 200 is sufficient for diagnosis. Unless for some reason you have that patient just hooked up by IV to a hummingbird feeder of sugar water. In which case, you don't actually need to worry about diagnosing them with diabetes because you're gonna go to jail for malpractice. Probably. I don't know. Medicine is weird. That might actually be a legitimate medical treatment for something. Moving on. Alternatively, you can have a fasting glucose level or an oral glucose tolerance test or an HbA1c level, and those can be used to establish the diagnosis. So if the hyperglycemia is high enough to suggest but not confirm the diagnosis of diabetes mellitus, then you kind of have to either get two test results that are similar, these are both weirdly high but they're not over 200, either from the same sample or a separate test sample, and then you can use that to confirm the diagnosis. Hi, Yara. I don't actually know what any of that means. That's extremely valid of you, and to be honest, I don't really either. So let's talk about it. First of all, we have 3 different tests that we can be looking at. We have the flasting. Wow, this is going great. We're going to take that again because I don't want any jokes about flasting or fisting or being flaccid associated with this video. So, we have 3 different tests. The first of all is a fasting plasma glucose, or an FPG, which is now what I will call it so that I don't say flasting again. 2, we also have the 2-hour glucose value after the oral glucose tolerance test, or the OGTT. And if you're me and basically a 13-year-old and did have to pause a video for about 5 minutes because you were laughing about flasting, that's the OG titty test. And 3, we have the hemoglobin A1C test, or the HbA1c test. FPG is literally exactly what you think it is. We don't let you eat anything for 8 hours, and then we measure the literal amount of glucose in your blood. Point of order, these are all venous blood tests. I shouldn't have to specify this, but I did say that these videos are for people who don't know anything. So these are venous blood tests because we try not to do arterial blood tests unless we can't avoid it. Also, a pro tip on the fasting blood glucose: schedule it in the morning because you can usually pull off not eating for 8 hours by virtue of being asleep for 6 to 8 of them. And if that isn't true for you, you have problems that getting a diagnosis of diabetes is not going to help you with. The OG titty test is kind of similar. So what we do is we measure an initial fasting blood glucose, and then we have patients drink 75 grams of oral glucose, which, is normally pretty gross tasting, but don't worry about it. Damn it, I was doing so good not saying don't worry about it, but don't worry about it, I guess. And then after 2 hours, after they've had that 75 grams of oral glucose, we take another blood sugar, and we sort of measure the differences, and we make sure that you're able to metabolize the sugar well. And then finally, we have the HbA1c test, or the hemoglobin A1c test. And it's our holy grail of blood testing because both the fasting blood glucose and the OG titty test kind of are snapshots. And the HbA1c is a broader range tests. And it's so great for reasons both of patients lying and also therapeutics being complicated and all things. So I will get into it later, hopefully still in this video. And it's technically a percentage. But we never actually say percent because all doctors want you to suffer, and we don't like making learning medicine easy. So basically, the term HbA1c refers to the percentage of glycated hemoglobin, and it develops when hemoglobin, which is a protein in the red blood cells that carries oxygen around the body, joins with glucose in the blood. And that's why we say it's glycated. And this measurement isn't as variable as things like plasma glucose levels because it takes time to sort of adjust. So it's quick, it's easy to measure, it's pretty cheap, which we love to see on tests, and it's less of a snapshot, and it's more like getting 3 weeks of receipts on someone. So if you've been having weird spikes of your glucose level, right, if the therapeutic management isn't working, that'll still show up on your HbA1c, even if your FBG that day is totally normal. Also, for example, let's say you forgot to take your medication for like 2 weeks straight, and then you take it for the 3 days leading up to your doctor's appointment, your HbA1c will be ganky. So just be honest with your doctor that you forgot to take it for a while, because the HbA1c is a snitch and it will tell on you. Okay, cool. Now we understand our big 3 tests for diabetes, so let's talk about actually interpreting them. First things first, I'm going to say a bunch of numbers and I'm going to say a bunch of units, but you always have to check because reference ranges change based on the lab that is testing the blood. So, I'm going to say, oh, it shouldn't be more than 7. Just check against the reference range that your lab report comes with. And if it's not normal, then, your lab report will probably flag it. Whatever, we're still going to talk about it. So, first of all, always check units because I'm talking about things in milligrams per deciliter, but you can also talk about things as millimole per liter, and you will see why these are so different. So we can talk about a flasting. God damn it. I am an adult, and I know how to say the word fasting. So let's talk about FPGs. So if you have an FPG of greater than or equal to 126, that's highly indicative of diabetes mellitus. Now, you'll remember that when I said for diagnostic criteria, it needs to be greater than 200. But if you have a patient who you are suspecting of diabetes and you're getting FPGs of greater than or equal to 126, that patient has diabetes mellitus. Now, I'm talking about these in milligrams per deciliter. And you're going to see that this is hugely different than if I was talking about it in other unit, which is millimoles per liter. Because in millimoles per liter, anything greater than 7 is diabetes mellitus. So you do not want to have a patient out here with a fasting glucose of 26 millimoles per liter and thinking, oh, this is grand, they're healthy. No, that person's going to die. You need to always check your units. So greater than 126 micrograms per deciliter, that's diabetes mellitus. And anything less than 100 is probably healthy. But Yara, you left out 26 numbers. I technically only left out 125 because that's how greater than or equal to works, but whatever, it's fine. So we're going to talk about the middle range. So anything from 100 to 125 milligrams per deciliter, is going to be in an impaired fasting glucose, and that's what you consider the pre-diabetic range. So patients in this range are at an extremely increased risk for developing diabetes, but they're not technically diabetic yet. So that plays a mind into therapeutics, but also remember when we talked about sort of the pathophysiology of type 2 diabetes and how you can get this postprandial hyperglycemia where you're not yet at a stage where you have fasting or impaired, like truly totally impaired hyperglycemia. So, that's kind of in that pre-diabetic, like you're on the way, but you're not all the way there yet. So that's the FPG values. So let's talk about the OG titty test. OG titty test has a lot cleaner numbers. Anything greater than 200 is diabetic. And again, micrograms per deciliter. I'm not going to keep saying it, but you need to keep remembering it. So anything greater than or equal to 200 is diabetes mellitus. Anything less than 140, that's healthy. Anything in that middle range of 140 to 199, you're back on your impaired glucose tolerance. That's your pre-diabetic range. Finally, we have our HbA1c, which I, again, cannot stress enough, is one of the most important tests. HbA1c of a greater than or equal to 6.5, that patient probably has diabetes. Now, again, this time you don't actually need units, right? Because I said that the HbA1c is technically a percentage. So greater than or equal to 6.5, that is diabetes. Anything less than 5.7, totally fine. Anything in that middle range, 5.7 to 6.4, pre-diabetic. Of note, you can't actually use the 5.7 to 6.4 range of HbA1c to be diagnostic of really anything. It's not an indicator of impaired glucose tolerance, right? It could actually be healthy glucose tolerance. So if you want to know if they're really truly in the pre-diabetic range, you need to go back to your FPG or your OG titty test. Great. I now totally understand those 3 tests and the values associated with them and how I can use them to diagnose diabetes. That was so easy. This is so quick. This video is done. No, there are many more tests that can be used. So let's talk about some of those additional tests. So the first thing we're going to do is the specific autoantibody tests, right? Remember we talked about how there is type 1A and type 1B of diabetes mellitus, right? So how do I know if it's the idiopathic one? How do I know if you don't have the autoantibodies? I fucking test for them. So we're first going to test for our favorite dude, which is the anti-GAD autoantibody. But we'll also do an anti-tyrosine phosphate-related islet antigen, which we like to call just IA2 because, again, way easier to say. So anti-GAD and anti-IA2 are going to be positive in about 90% of cases of diabetes mellitus 1. Great. And the other thing we can test for is the islet cell surface antibody, or the ICSA. And that'll be positive in about 80% of cases, but that's like way more expensive and way more difficult to test for, so we don't do it as much. And remember, you can absolutely have type 1 diabetes and just not have any of the autoantibodies, and that's why we have type 1B, which is idiopathic diabetes. And these tests are important because the treatments for type 1 and the treatments for type 2 are different. So you need to make sure that you know what the actual underlying mechanism of the diabetes in the patient is. So another thing we can do is we can look at the levels of C-peptide in the body. Now, you might remember from the last video, and if you don't, it's fine because I'm about to explain it again, what C-peptide is it's a byproduct of the formation of insulin. So the final step of insulin production is the cleavage of proinsulin into insulin and C-peptide. So the levels of C-peptide in the body give us a little bit of information about how insulin formation is going. If you have very low levels of C-peptide, that indicates an absolute insulin deficiency. Your body is not making insulin, right? And that's kind of more in line with type 1 diabetes. Now, conversely, if you have extremely high levels of C-peptide or even just elevated levels of C-peptide, what you might be having is your body is over responding and over creating insulin as an effort or an attempt to overcome peripheral resistance. And that's kind of in line with type 2 diabetes. And then there are a couple of other tests that we can talk about. So let's start talking about urine analysis. Shut up about the fact that doctors used to drink the pee. We know that they used to drink the pee. It's still gross. Shut up about it. So the first thing we want to look for is the levels of albumin in the urine. So we call this microalbuminuria, right? And that's the presence of low levels or low amounts of albumin in the urine. And that's important because it's one of the first signs of diabetic neuropathy, nephropathy. rather. Yes, those two things sound very similar, are very different. We're going to talk about them when we talk about complications. The other thing we're going to test for is, of course, we're going to look for glucose in the urine, or glucosuria. This is not sufficient for the diagnosis of diabetes mellitus. People having a high level of glucose in their urine is concerning, but it doesn't mean that they have diabetes. It can mean a lot of different things, and that's why we care about the FBG and the OG-TITI and the HbA1c. Use those for diagnostics. Use glucosuria because it's, it just strengthens your argument. It's not hard to test for. The other thing we're going to look for in the urine is ketone bodies. Now, remember when we talked about the various presentations of the two disorders, type 1 diabetes can present with a thing called DKA, right? And that's not good for you. So we're looking for high levels or positive levels of ketones in the urine because that shows that liponolysis. It's hard to say words. You're going to have to bear with me. Now, we care because that shows that liponolysis is not being inhibited in the body, and the body is breaking down fats into ketones at an unnecessary or an overwrought pace. Awesome. So what we've actually done is we have covered a majority of the testing and then the diagnostics that we care about when it comes to the diagnosis of diabetes mellitus. Now, the thing that we have to be prepared for always when we're looking at a disease is what could I mistake this for and what could be mistaken for it. So let's look at a little bit about the differentials. So the top differential for diabetes mellitus is diabetes. I'm not joking. So the top differential for type 1 diabetes is type 2 diabetes, and the top differential for type 2 diabetes is type 1 diabetes because they are extremely similar diseases, and it's extremely important to distinguish them because, like I said before, they don't work the same. So let's just go through a little bit about the differences between type 1 and type 2. So first of all, type 2 diabetes is way more common than type 1 diabetes. So about 80 to 90% of all cases of diabetes mellitus are type 2. So if you're just taking a shot in the dark, type 2 diabetes. The other thing is HLA association. So remember when I talked about type 1 diabetes, I said that having a DR3 or a DR4, HLA DR3, HLA DR4, I'm saying the full names, makes you 4 to 6 times more likely to have diabetes. Type 1. So that means that it has an HLA association. Now, type 2 has a genetic component, but it doesn't have an HLA association. So another thing that can be used to distinguish between the two is their pathogenesis. Remember, type 1 is an absolute insulin deficiency, whereas type 2 is an insulin resistance. And we can use that to sort of strengthen our argument one way or another, just like how we talked about earlier in this video with the C-peptide test. The other thing is the body habitus of the patient. Remember, type 1 is not associated with obesity, and in fact, one of its symptoms is weight loss, whereas type 2 is obesity is a risk factor, so that can kind of lead you down one path to another. Finally, we can talk about their onset. So type 1, you tend to have an acute decompensation. Remember, we talked about presenting with a DKA, and you typically see that onset before the age of 20. Now, that's not an absolute thing, right? You can have type 1 diabetes and present later in life. That's LADA. It's got its own classification. Now, type 2 tends to have that more gradual onset. They do tend to present usually after the age of 40. Right? And remember, none of these are absolute. They're just kind of used to sort of strengthen your argument in one direction or another. We already talked about the C-peptide thing. Now remember, I said that C-peptide being elevated means that it's type 2 diabetes, but it'll only be elevated in the beginning, right? As the body stops producing insulin, the C-peptide will go down. Type 1 has a more unstable metabolism, whereas type 2 has a more stable metabolism. That's not really helpful in terms of creating a differential. It just bared mentioning. And then the other thing is the ketoacidosis. If your patient is coming in diabetic ketoacidosis, they're probably type 1. You don't get that with type 2. And remember, the reason why we care about creating differentials, A, is so that we don't miss that it's a totally different disease, but also because distinguishing whether or not something is type 1 or type 2 is important because the treatments for them are different, right? Type 1 is an absolute insulin deficiency. How do we treat it? We give you insulin. Sometimes medicine is easy. And type 2, we do also prescribe insulin for that, but that's going to have a different set of treatments, right? Because the patient has insulin resistance. The problem isn't that they're not making insulin. The problem is that insulin isn't able to do its job. So I'm going to talk about two other differentials, and these are insane differentials to choose, and they're extremely rare, but I'm going to talk about them because they're on the AMBOSS page, and that's how I determine what's important. So the first one is a glucagon, a glucagonome, a gluca. Kill me. So the first one we're going to talk about is a glucagonoma. So that's an extremely rare neuroendocrine tumor of the pancreas. And when I say neuroendocrine tumor, what that means is that it secretes a hormone. And the hormone that it secretes is glucagon. And in about 50% of cases, by the time you've discovered that this patient has this tumor, they've already metastasized. So it's an extremely sort of virulent, I don't know what the correct term is. It's an aggressive tumor, but it's also extremely, extremely rare. Now, what do patients like that present with? And how come it's so easy to confuse it with diabetes? So the clinical symptoms are non-specific symptoms, and it is a cancer, so they do present with weight loss, and that's present in about 80% of cases. And then they also have this insane thing called necrolytic migratory erythema. That is its own very specific kind of rash, which I will talk about a little bit more later because it does help you distinguish that the patient presenting to you doesn't have diabetes. What they do in fact have is a tumor of the pancreas. Now, the other clinical symptom that these patients are going to have are, DVT, deep vein thrombosis and depression and chronic diarrhea. And then in 75 to 95% of cases, these patients will present with an impaired glucose tolerance or diabetes mellitus. So the reason why these tumors are confused with diabetes is because what the tumor does is it gives you diabetes. And this makes sense because we remember that insulin is created in the beta cells of the pancreas, and there's a giant tumor sitting on the pancreas. But it's also important because what the cells do, the tumor cells, they secrete glucagon. And glucagon's job is basically the opposite of insulin. What it does is it dumps out sugar into the blood level. So increased levels of glucagon means increased levels of blood glucose, which is basically the primary symptom of diabetes, and it's the primary cause of a lot of the complications. So it's very easy to confuse these things. Now, the necrolytic migratory erythema is present in glucagonoma, but it's not commonly seen in diabetes. You can get rashes, you can get a ton of things with diabetes, you get ulcer, whatever. We're going to get to that stuff. But this specific thing is it's these occurrences of these weird, I don't know how to describe these. I should have made these videos in a way that I can show images. Google it. Actually, don't Google it. It's pretty gross. But it's these multiple areas, and it's usually on the face or the lower extremities. So it's pretty, you catch onto it pretty quickly, and they're crusty and they're painful, and they'll be bronze colored, and they'll have these areas of necrosis in them. So it's gross. Man, it's gross. It's a gross rash that shows up in weird places like the face and the perineum and the lower extremities. And this rash isn't unique to a glucagonoma, right? This shows up in other things like hepatitis B and C, and also in some bronchial carcinomas. But what's important is that it doesn't show up in diabetes. So if you have this patient who has diabetes and also has this weird sort of necrolytic migratory erythema, or they're also presenting with some other symptoms, like it's a type 2 patient, they are not showing any autoantibodies, and they have what appears to be a type 2 diabetes, but they're aggressively losing weight, then you need to start thinking about other things. Right? And that could be, this patient doesn't actually have type 2 diabetes. What they in fact have is a glucagonoma. Also, quick plug right here, though. Patients who you think probably have diabetes are more likely to have diabetes than anything else. A horse is a horse. It's not usually a zebra. Right, and it's important because the treatment for a glucagonoma is, we need to have that glycemic control, right? Because those high blood sugars, like I said, kind of in a sidebar, that is the cause of a majority of the complications of diabetes. And you also can do a couple of other things, but with these patients, you probably are going to have to do a pancreatic resection. Now, you might be too late by the time you've discovered it, but I made that joke earlier in the first video that I was like, haha, we gave you insulin because we removed your pancreas. Sometimes we be removing people's pancreas. The other crazy differential to kind of talk about is a somatostatinoma. No, I'm not going to try to pronounce that again. Now, that's another rare neuroendocrine tumor, but that's of D cells, And D cells are cells that are located usually in the pancreas or the gastrointestinal tract. And I said it's a neuroendocrine tumor, and what it secretes is somatostatin, hence the name somatostatinoma. I said I wasn't going to say it again, but there I am. Right, and that's going to have its own set of symptoms sort of associated with it. So that's, abdominal pain and weight loss and this thing that we call achlorohydria. Okay, that's when your stomach acid is messed up because you're not able to make HCl appropriately, and that's going to be because of some of the actions of somatostatin. Now, what's important with this particular neuroendocrine tumor is it has what we refer to as a classic triad, which in medicine is just a way of saying, hey, when you see these three symptoms presenting together, like it should raise your suspicion of something. And for somatostatinoma, what that is it is glucose intolerance, right? It is that presence of sort of diabetes mellitus-esque symptoms, but combined with cholelithiasis and steatorrhea. Again, random medical words, I will explain. So what that is it's your glucose intolerances combined with gallstones, or the presence of gallstones, and fatty poops. Man, I'm not, that's poop. Poop is very important for medicine. And all of these symptoms are sort of brought on by the actions of somatostatin, which we will not get into in this video. But what's important to understand is, like, when you have patients with diabetes mellitus, that's not the end of the conversation, because while it could just be, oh, it's a type 2 onset, or oh, it's a late onset of type 1, and right, you always have to have a little bit of a suspicion because other things can secondarily give them diabetes. Right, and the treatment for somatostatinoma is different than the treatment for diabetes mellitus because the problem isn't with insulin, the problem is with somatostatin. So what we're going to do is we're going to give them a somatostatin inhibitor. Don't worry about the names of these things because we'll do drugs when we do drugs. And don't do drugs, kids. The other thing that we might do is that pancreatic resection. It's curative for this particular cancer. If there's no metastasis, removing of the pancreas will cure this patient. And then if that's not an option, or if there are mets or things of that nature, chemotherapy is another option for treatment. Okay, so we're going to actually cut this video here because I think what we want to do is we're going to talk about the complications of diabetes and the clinical findings of diabetes and the treatment of diabetes sort of as one bundle, even though that will make that video longer. But I think that makes more sense than just kind of plowing through. And I do not want to make another 30-minute video, so we'll sort of see how this works out. So anyways, that was diagnostics of diabetes and differentials of diabetes and sort of how we need to be thinking about it when we're looking at patients as they come in. Next time, we will do complications and clinical signs as well as treatment of diabetes. It'll be fun, I promise. I'm lying. See you next time.